Alright, so what we've got here is a special topic on OB ultrasound. This is a talk that's highly anticipated, and a lot of people have been very interested in this, and I'll tell you that this is probably the lowest yield topic for actual questions on the exam. You might get 3 questions on this, and out of those 3, 2 of them will be incredibly easy. You would have been able to get them right probably without even studying, and the other one will be so poorly written that no matter what degree of mastery you have of the material, it'll be impossible to get right, and it may or may not get thrown out depending on how the statistics work. Nonetheless, it is a source of great anxiety for people, and you may say, well, why? Why would it be a source of just great anxiety if it's such a low-yield topic? Well, that's because you get very little exposure to it in training in the modern era. About 25 years or so ago, radiologists started doing what they do best, which is teach other people to do their job. Usually this is done with procedures, but it is also done with imaging, and it's continuing to happen now. So they decided they were going to teach the OB doctors how to do all that ultrasound, because who wants to do that anyway? And then, and they decided to take all of it. So most programs, especially the larger programs, you get, the first trimester OB stuff that comes through the ER, and then you don't ever really see second or third trimester OB. And then what ends up happening is, over the course of 20 years, it's very likely, depending on what area you're attending's trained in, they don't really know how to do it either, so they can't teach it to you. So anyway, luckily I'm here, so I'm gonna go through it in a way that I think I've got a system where I'm going to attempt to teach it and hit the high points. Can't learn everything, but I think that we'll cover those 2 questions that you can get right out of 3, and that is not bad. 2 out of 3 is not bad. Alright, so here is a cartoon of a sagittal view through the brain and cerebellum, and the reason I show you this is that there's 3 standard views of the brain that are done with like second and third trimester fetal ultrasound. There's the transventricular view, which is through the ventricles, transthalamic view, which is a cut that's a little bit lower, and then you've got an angled cut, which is this transcerebellar view, and that goes sort of like that. So what I'm going to do is I'm going to go through each one of these cuts, sort of introduce the anatomy, and then talk about what the pathology that's relevant for each slice, and that helps with gamesmanship. So if you can recognize what slice you're being shown, then maybe you can sort of eliminate some distractors of like, well, you can't see that on that slice, or have a good idea where they might be going with it. It's helpful. So let's start with the transventricular view. So here we go. This is an axial slice through the lateral ventricles. It's attained at the level of the frontal horns. These guys, the frontal horns of the lateral ventricles, and the cavum septum pellucidum, which sort of looks like a little box there, and then you can see the atrium of lateral ventricles. So this is the important part. I'll do a zoom up here. So remember that the atrium is the confluence of the temporal and occipital horns, and it contains these bright things, which are the echogenic choroid plexus. All right, so what's the important thing to know about this particular view? This is the view that you're going to look for to see hydrocephalus. Now, just a gamesmanship thing, you will probably notice as we go through, and if you ever actually see any real cases, that the bottom half tends to be the one that you can see a little clearer with regard to looking at the ventricles on this view. And because of that, if you're going to pick one to make, like let's say you can't really decide, you're between one or the other one, make your decision based off the bottom one, okay? So you make a measurement from here to here, just inside the borders of the ventricle, and 5 to 10 millimeters is considered normal within the second and third trimester here, okay? So if you get shown a case, it'll probably be something like this, where it's like really blown up. It's like because you're not going to have a chance to really measure unless you can calibrate it off your fingernail, that it's going to have to be obvious that it's dilated. I guess they could just straight ask you what the measurement is, but I think that's less likely. But in case somebody would ask, like I said, 5 to 10 is normal, 10 to 15 is mild usually, and then greater than 15 is considered severe, and that would be a case like this would be severe. You can see that the choroid is dangling. Sometimes people will use that as a buzzword, dangling choroid. So when you see this, remember we're talking about congenital stuff, so you have to think about congenital causes. The first thing I want you to think about is structural cause, like aqueductal stenosis, like from a little web or something in there. The other thing I want you to think about is torch infection, specifically toxo. Even though CMV can do it, toxo is usually the one that people talk about more with congenital hydrocephalus. All right, so another thing that you can see on the transventricular view, which remember is like basically a view of the ventricles, are these things right here, these choroid plexus cysts. So this is, people will call these things soft markers for trisomy, and here's by far the most likely question, in my opinion, is that it's trisomy 18. So I've mentioned in some of the PEDS talks that if you're not sure what the association is, guess downs, and you'll be right like 95% of the time. This is an exception. So it's actually more common to be with trisomy 18 than 21. So if you can remember one that's an 18, this is the one to remember. So 1% of the time when you see these choroid plexus cyst, they've got a trisomy 18. So that means 99% of the time when you see one, that doesn't mean shit. Now, when it tends to be matter a little bit more is if you start to see some other sort of soft signs as well, like clenched fists and those kinds of things. Like maybe there's a fluid, the fluid's not quite right, or there's other things going on that are a little bit worrisome, but they're not necessarily hard markers. Then you start ramping up your suspicion. Now, having said that, about half the patients with trisomy 18 have choroid plexus cysts. So just reviewing this because you could see how this could be written as a tricky question. You see them out in the wild. They're common. Trisomy 18 is rare, a rare thing. Okay, so only about 1 in 100 times when you see one is it going to actually matter. But if you had a patient population that was all trisomy 18, half of them would have choroid plexus cyst. All right, so next view. So that was the transventricular view. Now let's talk about the transthalamic view. That's the next cut down. Okay, so this is a cut that is through the thalamus. Okay, hence the name transthalamic. All right, so it's a midline. These are all sort of midline. Remember, we're not angling here, so it's an axial cut through the thalamus. Now, the thalami are these things. Some people will say they're arrow-shaped, and the arrow is pointing towards the back of the head, like that way, like maybe an Indian head arrow, one of those rocks, sharpened rocks. But it's pointing. That's pointing back. And in front of that is this cavum septum pellucidum, which sort of looks like two little lines, drawing a box around it there. All right, so the main utility of this particular view, and what you see most people doing, is this is the view that they do all the measuring for growth. So you can measure this biparietal diameter, and a possible question with regard to that is, where do you measure it? So you're supposed to measure it from the outer edge of the near to the inner edge of the far. So how I remember this is upper. So the upper edge to the upper edge. So upper, and that's your outer and your inner for this one. Or you can just remember upper, and that will help you keep that straight. This is also the same view where the head circumference is drawn. So this is exact same plane. You should not, so sort of some housekeeping, you should not be able to see the cerebellar hemispheres, because that way, if you would see the cerebellar hemispheres, that means that the tech angled the probe. You don't want it angled. It should be like an axial slice, so you're not off axis to make your measurement falsely large or small or whatever, but it's done around the outer edge of the calvarium for head circumference. So this was biparietal diameter, which is the diameter, the upper, and then head circumference is the circle around it. Circumference. Makes sense, right? So those are two of the views. Now here's another question that could potentially be asked, is that what if it's an ugly baby? What if it's got, one of those weird shaped heads, like a brachycephaly, dodecacephaly, like those kinds of things? So which one's going to be more resistant to that? So biparietal diameter is actually more vulnerable to ugly babies. Remember, so if you had a long skinny head was shaped like a hot dog, something like that, then this would be messed up. But if we still had our hot dog head here, this might be a little bit longer. This is shorter, but that's longer, so it cancels out. So the head circumference is more resistant to ugly babies. All right, so we said that we have biparietal diameter and we have head circumference. The other things that are used are the femur length, which is done from the center point of each metaphysis. And here's the important part here. You don't include the lower part of the femoral epiphysis. Now, you're not even going to see that typically until late pregnancy, but just know that it's metaphysis, okay? So that's femoral length, and then there's abdominal circumference, okay? So let's talk a little bit more about that. So here, the tech, we've got a new sonographer on the job here, and it's like a QA thing, which they've measured abdominal circumference on both of these images. Which one are you going to count, or which one's best, or which one do you throw out, or which one do you yell at the tech, and which one do you say, good job? All right, so this is the one you want, and here's why. Okay, you want to see the stomach, and you want to see, in this case, it's sort of an upside, well, it sort of looks like a J. Some people say this looks like a J. So those are the two structures you want to see in plane, and that's how you know that you're measuring your abdominal circumference in the correct plane. You should not be seeing the kidneys, and then, like, also in this case, we're not seeing their stomach bubble, and we're not seeing that J-shaped thing. So you look for the J and the stomach bubble for the level that you're supposed to measure the abdominal circumference. Now, another pearl is that you're not supposed to include the subcutaneous soft tissue. You're just supposed to, like, if you were going to measure it, you would measure it right here. You would not measure it out here. Just real quick here, I wanted to clarify something that I mentioned before. I mentioned this J-shaped structure that you'll see on that umbilical or that abdominal circumference view, and I just want to point out what exactly that is, just in case somebody would ask. So here's a cartoon of the liver, drawing the portal system on there, labeled the left portal vein. And here comes the umbilical vein. So the umbilical vein communicates with the umbilical segment of the left portal vein. And you can imagine that depending on the cut you were looking at, maybe that there might sort of look like a J. So that's what you're seeing there, is that confluence of the left portal vein and the umbilical vein. All right, so who cares about that? Why do we do that? Well, one of the things you want to be looking at is the kid growing normally? If he's not growing normally, you may think that he has an intrauterine growth restriction. So there's a bunch of different ways to sort of come to that conclusion. You can estimate the fetal weight based on some measurements, and if they're below the 10th percentile, that might be what's going on. You can do ratios. Some people talk about the femoral length and abdominal circumference ratio. You can also look at this umbilical artery systolic to diastolic ratio, and we'll talk about that here in a second. Now, You might imagine that this one's not sort of as useful, maybe, because what if you have two little people, right? Not everybody's, Shaquille O'Neal's kids are probably going to be above the 10th percentile in size, right? But what if you have two small, frail Asian people have a kid, and they might have a kid that's a totally normal kid. He's just below the 10th percentile, is just a little kid. So just something to put in the back of your mind. But again, these sort of make you wonder whether or not something's going on. So let's talk about this umbilical artery systolic to diastolic ratio. So basically, as you progress in gestational age, the umbilical artery resistance should get less and less and less. And the general rule is that 2 to 3 is 2 to 3 at 32 weeks. In other words, 2, 3 at 3, 2. It should not be more than 3 at 34. So the way that I think about this and remember this is you're basically, as the kid's growing, he's becoming more of a person. That's why some people disagree with late-term abortion kind of stuff, because it's like a person, whereas like early on it's maybe not a person as much. It's just a clump of muscle. So I think about like muscle and brain as far as the resistance pattern. So remember that like external carotid has a high resistance pattern because you want to be able to sort of turn that thing on and off, whereas the brain requires continuous diastolic flow, so it has a low resistance pattern. So remember, like, the difference between, here and here, large difference is a lot of resistance. Small difference.
Dad, I'm staying here. Aren't you going to play with me?
All right, okay, so back again here. So basically the rule is two to 3 at 32. Okay, so 2, 3, 3, 2. And what I'm saying here is that a ratio of systolic to diastolic ratio of 2 or systolic diastolic ratio of 3, in other words, less than 3 at 32 weeks, never more than 3 at 34. And that's the hard number to remember. And so this idea is that as you get older and mature as a baby, you become less of a muscle and more of a brain. So you early on, your resistance pattern is similar to a muscle. Just like, remember the resistance patterns in like the external carotid, like for the facial muscles. They're high resistance. You can turn them on and off. Whereas a brain is a low resistance structure and has, it's more like continuous, diastolic flow is required. So just think about that. Like, as you get more of a brain and less of a clump of cells, you start acting more like a brain and less like a muscle. All right. So if you see these things, is the kid screwed? Like, is it an intrauterine growth problem? Is the kid hosed or not? So, like I said, maybe not. Maybe he's just small. Maybe he's got small parents, and maybe he's just small. So if he has normal Doppler studies, in other words, if that systolic diastolic ratio is normal, then he might just be fine. However, what you might want to do is you might want to look at his fluid status, one of these things. So there's this entity called an amniotic fluid index, or an AFI. So if the kid is measuring small and he has low fluid, which they call oligohydramnios, or if he has high fluid, which they call polyhydramnios, he's probably fucked. He's probably getting a peg tube, and if he makes it, he's not having a normal life. No cheeseburgers, no soccer for him. Instead, lots of suffering and lots of medical bills, and parents are getting divorced. all those kinds of things. So a single motherhood is in your future, statistically anyway. So let's talk about this amniotic fluid index, because they could show you a picture just like this, and they could say, well, what is this? Or is this normal? Or what other associated anomalies might you think going on? So amniotic fluid index is, there's measure these different pockets of fluid, and, so early on, where does the fluid come from? Early on, really early on, you have fluid that's basically a filtrate from across the membranes. But after about 16 weeks, the fluid is actually made by the fetus. What does that mean? It means he or she is peeing it out. So the fluid is basically pee. And that helps you remember what if there's not enough fluid. So if there's not enough fluid, there probably is a renal problem because you aren't peeing enough. What if there's too much fluid? Well, you pee it out and then you swallow it. As disgusting as that sounds, that's what's going on. So the fetus is peeing and it's swallowing the amniotic fluid continuously, and that's actually helping the GI tract mature, and it's also helping the lungs mature. So if there's too much fluid, that means you're not drinking it, which means you might have a GI problem. So oligo, not enough. AFI would be less than 5. Between 5 and 15 is normal. That means that you're not peeing enough, which makes you think that there were GU anomalies. Poly means there's too much. So an AFI greater than 20 or a single pocket greater than 8 means you're not drinking enough of the pee. This is the one time in your life where you just, not drinking enough pee is a bad thing. So that means that you have an issue with your GI tract. All right, so going back to this. All right, so is all intrauterine growth problems, are they all the same? And they're not. There's two main types. So the first snowman here is sort of the normal appearance, and then I've got two different snowmen here. I've got one that's totally skinny, and then I've got one that's got a skinny body but a normal sized head. All right, so this is the symmetric and the asymmetric types. So when you're thinking about the symmetric one, this is a kid who this is bad because the body's normal reaction is to protect the head. Always want to protect the head because that's where the brain, stuff like that. So a preferential protection of the head. It's going to spare that if it can normally, and then it'll go last if you're really in a bad situation. But if you're not sparing the head, and the head is small and the body is small, then you think about like the mechanisms are fucked up. So this might be a chromosomal problem, or the kid's getting poisoned, like fetal alcohol syndrome, or torch infection. So you'll see these things throughout pregnancy. So this is the bad kind. It's the kind with congenital malformations. This is the kind with bad infections or poisons. The alternative kind is the asymmetric kind. So this, like I said, this is the head-sparing kind. And this is the kind where you see this later on, like third trimester kind of stuff, where you got a kind of a normal kid, but maybe you've developed some high blood pressure issues or malnutrition, but the background genetics on the kid, like I said, is normal, so it's doing what it's supposed to do and protecting the head, and these tend to have a better outcome. So just sort of like an idea here on what is supposed to happen normally. So you're supposed to sort of have a big head, little body, and then as you age, that head circumference to abdominal circumference ratio changes till when you come out, you're although kids do still have big heads, they tend to have their belly be a little bit bigger than their head, and that's normal. So they have like charts for like what you're supposed to be at what age. for these ratios, but you don't need to measure. Just it's concept. It's concept. All right. So we talked about transventricular view, ventricular view. We talked about transthalamic view, and now let's talk about the last one here, which is this angled one, this transcerebellar view. And like the cut is the first two were sort of axial. This one's at an angle. All right. So, what can you see on the transcerebellar view? Well, you can see the cerebellum. And the cerebellum is got a contour that is sort of dumbbell shaped, and that's the normal contour. And then behind that is the cisterna magna. That's this thing. And then behind that is this nuchal, the nuchal translucency, which in this case is normal, which means it's very small. So you probably know that nuchal translucency is a thing that people do use as a Downs marker. So we've got, this is similar to the case that I showed before with the abdominal circumference. So which one of these two kids is, tech? We got a new tech here giving you two images. Which one are you going to use and which one are you going to throw out? So this is the this is the one we're going to use here. This guy. This is the one we're going to use, and the reason we're going to use it is because you want the kid to be totally in profile. And how do you know he's in profile? You can see his nasal bone. All right. The other thing that you want is you want the kid's neck to be in a neutral position. What does that mean? That means that this line here is straight. Okay. See how that's straight as opposed to this. See how his head is sort of got this angle here. This can mess with your measurement. So you want it totally neutral, and you want the head. You want to be right in the midline, which means that you're seeing the nasal bone. We're not seeing the nasal bone here. And his head's got this angle here, so this is wrong. All right, so here's the measurement is, less than 3 millimeters is normal. More than 3 millimeters, you think Downs. Bigger the measurement, the more likely something is wrong. It's measured at a specific time, somewhere between 9 and 12 weeks, sort of institutional. Some places you'll read will say 11 to 13, but there's a tight, narrow window. You can't just measure this thing at any time. Everything's standardized. So like between 11 and 13 weeks or between 9 and 12 weeks, you're going to do this measurement here. You're going to measure it with a specific plane right dead in the midline where you can see the nasal bone, and you want this totally neutral here. Positioning is critical. It's very important. So, all right, so that's that. Now let's go back to, let's mention one more thing about the cerebellum. So there's this idea of this transcerebellar diameter, which is basically the measurement here from top to bottom. And the general rule is that if they would give you a picture like this and then they would say date the kid, you can do that. That's something that, like, I've seen OB attendings pimp OB residents on this, date the kid based on this measurement. So between 15 and 22 weeks, every millimeter is a week. So 1 millimeter equals 1 week of gestational age between that time period. All right, so let's take a look at this, sort of a this versus that, between the normal cerebellum and what's not normal. So remember, I mentioned that this cerebellar contour here, that's really important. And this, it's sort of like a dumbbell, like with a weight on one end and a weight on the other end, and then the little rod thing that you hold on to is in the middle. Well, that rod thing is the vermis. So what we've got over here is we've got a dumbbell and a dumbbell, but we don't have the rod thing in the middle, and so there's no vermis. So vermal agenesis is part, that's the crux of the Dandy Walker, right? So that's how Dandy Walker is shown on a fetal ultrasound. Sort of the middle part of the dumbbell is missing, and more than that, also notice there's expansion of the cisterna magna, where it was it's little back here, but over here it's bigger, and it's got like a dip in it like that, so it's sort of got this kind of a shape. sort of like a mountain, maybe, or a ghost, one of those, or one of those cookies from Arby's, the star cookie. That this one didn't get formed right, so just sort of like a Dandy Walker didn't get formed right. All right, so moving on. Okay, so this is an Ant Mini. We got a little guy and we got a hole in the head. Little guy with a hole in the head. All right, so this is one of those classic tricks, right? Looks like a bad thing, but it's not. This is the normal cystic rhomboencephalon, all right? So the key component is that it's not a Dandy Walker malformation. So if they're going to show you Dandy Walker on ultrasound, they're going to show it like that. They're going to show you that transcerebellar cut, and they're going to show you the dumbbell sort of pushed apart with the middle part missing, the vermis missing. This is how they're going to try to trick you into saying Dandy Walker if you don't know what you're talking about. So it's a normal developmental thing between 6 and 8 weeks. And this obviously looks like a first trimester ultrasound, and this is probably what you're more used to looking at. All right, so now I want to talk about two signs that we see also on this transcerebellar cut. So the first one is the banana sign, which is this abnormal shape of the cerebellum. And the next one is the so-called lemon sign, which is how the skull sort of looks like a lemon instead of sort of a normal oval shaped. And both of these things are seen in situations where you are leaking CSF, like if you had a spina bifida defect, like you see sometimes with these Chiari-2 malformations. So, got two transcerebellar axial cuts here, seeing the cerebellum, and this is the normal contour of the cerebellum, right? Dumbbell with the vermis in the middle, so it's sort of got that kind of a curve like that. Now I want you to contrast that with this one over here, where the shape is the opposite, like that. Now another thing to mention also is that see how we've got like normal cisterna magna CSF space back here? We don't see that. It's like crowded. So that's the supposed pathophysiology, is that you've got a lumbar spinal myelomeningocele leaking CSF, and that's creating a hypotension in the subarachnoid space, which then is resulting in a prolapse of the cerebellum into the foramen magnum, and then it's reverses the shape because it's smashed down in there. So that is that's the banana sign, and then we've got this here. So look at the normal shape of the skull. This one's normal, and then look here how it's shaped like a lemon. So again, that's supposedly related to low pressure from CSF leaking. Again, both of these things resolve from around 24-ish weeks. So you'll see them. This is only seen during a certain time period. So both of these are neural tube defects. So as I mentioned mention another neural tube defect. So we've got a normal profile here. And this is the way that they typically will show anencephaly, is this profile here, because they want you to see this, which is the orbit, because anything above the orbit is supposed to be gone with anencephaly. So you have total absence of the cranial vault and brain above the level of the orbit. And this right here will set you up for a promising career in writing and constructing board examinations. So this person here maybe is writing some of your questions. They would be talented at it. All right, so this is the part of the talk where I sort of switch gears and get away. So from the beginning, everything that I did was sort of based on those three cuts through the head, and now I'm just gonna sort of cover all the rest of the crap that I think could possibly show up on on this particular section. Obviously, it's not everything, but this is stuff that I think that's highest yield. Sort of some Ant Minis. All right, here we go. So again, I've got I put a normal here, and this is what we've got is a face in profile. It sort of looks like a person in there, and then I want you to compare it with this, and we're zoomed in up in this region here. I'm not sure if this, hopefully this will project well, but there's a hole in the lip. Now, cleft lips are much easier to show than cleft palates. Can you see cleft palate on ultrasound? Yeah, you can see cleft palate on ultrasound. Man, it's tough. I think that if they're going to show you one, it's going to be cleft lip. It's the most common fetal facial anomaly, and about 30% of the time you're dealing with a chromosomal abnormality. Supposedly around 80% of babies with cleft lips have cerebral palsy. So if you see cleft lip, but I mean, obviously you can see cleft lips in isolation, but that would be the way that I think that it could be tested. What is it? And then just sort of knowing that 1/3 of the time chromosomal abnormality, or 80% of the time there's cerebral palsy association. All right. Again, so this is sort of what we're used to as a this versus that. Now, this here, what we've got is, I'll put the arrows on here. We've got this thing sticking out here, and that's not a foot. And I'll tell you that it's a girl. And in this situation too, we're a little bit older here. We've got something coming out right around here. It looks like it's contained, so it's probably figured out this is an omphalocele, and this here is the normal midgut herniation that occurs early, between 6 and 8 weeks, and sometimes you'll see it persist up to about 11 weeks. You may remember from embryology that your gut sort of is too big to sort of do its spinning stuff while trapped inside a closed abdomen, so it goes out, does a turn, and then comes back in so that you're normally rotated. And that happens for everybody. Well, an omphalocele is, it's a midline defect, and it's a herniation of gut at the base of the umbilical cord. So some things to know, just a quick refresher. There's a bunch of associated things. Omphalocele tend to do badly. Cardiac abnormalities like 50% of the time. GU, CNS, Turner's, Klinefelter's, Beckwith-Wiedemann, lots of different stuff that's associated with omphalocele. Trisomy 18, this is another one of those trisomy 18s, more than 21. You'll see written. It's midline, mentioned that twice now. And it has a membrane covering. Those are distinctions from gastroschisis, which is a similar pathology. So this is the other way that it might actually be more commonly shown. So we've got this one here, and then showing it like this, like in cross-section. And the reason that I say that is because you can tell a couple of things. You can tell that's where the cord is coming in. You can tell that it's clearly confined within a sac, and you can also see that it's totally in the midline, right? It's not off to the side, and that way you wouldn't be confusing it with a gastroschisis. It could be fair to have that listed as a distraction. Whoever writes the question wants to put that as a distraction. So in this situation, we've got our omphalocele showing you that same cut that I had before, and then over here we've got gastroschisis. So I'll sort of walk you through. It's this sort of frond-like thing hanging off the side, and you can see that the cord is here, so it's not in the same sac as the cord, and it's clearly not midline. So gastroschisis is this evisceration of the bowel, right? Sometimes stomach and liver. Also through an abdominal wall defect, but the difference is that it's not surrounded by a membrane like omphalocele. It's not midline, it's to the right typically, and it's got way less associated abnormalities. You can have an elevated maternal serum AFP, and I just think about that as, you're dumping shit like into this into the amniotic fluid, so it's picking that up and making the water dirty. But yeah, the outcome is significantly better for gastroschisis relative to omphalocele, which is sort of counterintuitive because you think, man, this thing's still stuck in a sack. I'll just push it back in there. This guy's got a huge defect in his abdominal wall. That's a bigger problem, but it's the associated congenital abnormalities that make this guy have a worse outcome than him. So remember I said that this is the more common way to show this. I think that gastroschisis is more likely to be shown like that. And the reason is it's like, oh, it's obviously a bunch of bowel, right? There's bowel signature out of the body. It's clearly bowel. There's nothing else that's going to be. So it's a slam dunk, so it's easy. It's fair. Let's not say it's easy. It's fair. It'd be fairer to ask it like this, and it would be more fair to ask it like that. But that's another way that they could show it. All right, next case. All right, we've got two bubbles, double bubble, just like on a plain film, just like on an MRI, you can show a double bubble on a fetal ultrasound. Okay, so what you're seeing is stomach bubble and dilated proximal duodenum, right? Remember that the atresia is slightly distal to that. Remember that the atresia is usually a solitary atresia because these occur from cannulation failure, not from vascular insult like you see with jejunal atresias, which tend to be multiple. There's a Down syndrome association. So here's a little bit of gamesmanship too. They could show you this cut. This would be really tricky, but they could do this because it's sort of a practical thing, and for some reason people want to pretend that multiple choice has any kind of practical correlation, but we'll walk through this. So here's a cut. You'd say, oh, that looks normal, right? Almost looks like that cut that you would measure the abdominal circumference on, right? We've got the stomach bubble, and we've got that J-shaped confluence of the umbilical vein and the portal vein. But I will tell you that you can't really see a double bubble on that usually. You have to take the transducer and point it towards the baby's feet, caudal. And when you do that, then you get this cut. So that's literally the same patient with the next slice down. And now you're seeing that double bubble. So it's sort of out of plane at that sort of standard view. So if they were asking for an exclusion or evaluation of duodenal atresia, you would say a next step would be angle the probe down. All right. Next case here. So just to orient you, here's a spine. This is like a sagittal view. This is the bladder. What we're seeing is a dilated proximal urethral dilation here, and it's posterior. So this is a posterior urethral valve. Some people will say that looks like a keyhole, like that. If you turned it that way, like on its side, it would look like that. Maybe keyhole sign. It's a buzzword. Posterior urethral valves. They could also show you that, which is hydro. That's like a axial cut hydro. It's not a double bubble. All right, now let's do some cardiac stuff. Just real quick cardiac stuff. I'll just give you my 2 cents on what I think is fair game. I mean, hell, they could literally show anything. And I was actually going to do a second part of this talk that was full-on congenital heart, but fetal ultrasound, and I said, no, not going to do it. And here's why. It ceases to be a board review course when you do stuff like that. The yield is so incredibly low. I mean, I don't know what's on the Q bank that they have for the test, but I cannot imagine that there is any more than one question out of thousands that's a hard congenital heart case. That's one that we're not going to show here. That's based on fetal ultrasound. They can show you hard congenital heart cases with cardiac MRI or plain film, stuff like that. And I do talk about that in other talks, but I'm just not going to go down that because I could do a 3-hour talk on that, and I'm just not going to. So I'm going to take 3 hours and I'm going to make it 3 minutes on what I think is 95% chance of what they would show if they were going to show something like that. So just like cardiac MRI, you've got standard views of the heart, okay? And this is one of them. This is a 4-chamber. And this is the money shot. This is sensitive for detecting 75% of the problems. And you can sort of figure out like what you're looking at. Like, so like, those are the ventricles. So how do I know they're the ventricles? Because the muscle's thicker there, right? And they're also bigger. So those are the ventricles. Those are the atria. And then you probably said, hey, there's an ASD. Well, maybe. But remember, this is a kid in utero, so they're going to have like a patent foramen ovale, right? So, and it's really hard to tell the difference between a patent foramen ovale and a small secundum ASD. So if they do show you that, I don't think they can list both a small secundum ASD, which remember that's the common one, and a PFO, and have you be able to distinguish between that. You can't practically distinguish between that very easily, or at least I can't. So you would hedge on that. So I don't think that, I mean, if they could ask, they would have to tell you one or the other as distractions. They couldn't list them both. What they can show you is this. So orienting yourself again, muscular part of the heart, ventricle, atrium, and notice there's the hole. That's the hole there. So that's a VSD, right? So that would be easy to show. That would be fair game. Or they could show you this, which some text will list as the easiest cardiac abnormality to identify on a 4-chamber view, which is the hole in the middle. So it's a hole right square dead in the middle, and that's like your AV canal defect. So if you see that, and just so that we're clear on what we're supposed to be showing here. So this is, let's say that's a ventricle, that's a ventricle, that's a atria, that's an atria, and we got like a hole right here, okay? Okay. That is an AV canal, and that's what that looks like. It's like you shot a hole through the middle of the heart, like right there. AV canal defect, Down syndrome. Boom. All right? And then lastly, there's this thing. Boom. This is your echogenic intracardiac focus, or your EIF. It's basically a calcification of papillary muscle, usually the left ventricle, but you can see them. You see them all the time. They don't mean that much, but again, it's one of these soft markers. Higher rate of trisomy 21 and 13 to lesser degree, and it's supposed to trigger you to look for other features. So it occurs in a normal population about 5% of the time, but you see it more in Downs people, which is like around 12. So it's supposed to make you say the patient could have Downs, they don't necessarily have Downs. It's a soft marker. Alright, so twins. Alright, just a quick twin thing here. I think I have this in my case book or Crack the Core, can't remember. It's in one or both. But basically it's the difference between this thing, the T sign, and that thing, the twin peak sign. And the difference is, the T sign is just a thin membrane. The twin peak sign is the piece of meat. So the T sign is basically the absence of the twin peak sign. So this is a monochorionic, so one chorion shared, and this one is a dichorionic, so we've got one for each, so dichorionic, diamniotic. Obviously these are both diamniotic. They both have their own sac, but whether or not they're sharing a chorion is the distinction here. So T sign, monochorionic, twin peak sign, which is the meat like a mountain peak. That's the dichorionic. All right, and then twins get twin transfusion stuff, and especially if you're sharing chorion, and they end up with terrible things that can happen to them, like this. So what I'm showing you here is really thick skin, abdominal wall edema. We're at the level, we're in the heart here, so the lungs floating, big pleural effusions, and we're down in the abdomen, big bunch of ascites. So all this is bad. So fetal hydrops, it's a bad thing. It can be from immune or non-immune causes. The most common cause is probably RH sensitization from prior pregnancy. That's why they give you that shot, Rogam or whatever. Some other causes: torches, Turner's, twin stuff like you said, alpha thalassemia, and basically, if you've got pleural effusion or pericardial effusion or subcutaneous edema, you need to call it. Boom. And this would be another way that this could be shown, would just be like this baby with like really horrific edema like that. Eye drops. All right, okay, that's it. I think that's everything that they could ask reasonably for second and third trimester OB. Yeah, there's other stuff out there, but that, again, it's a low yield topic, and that there's probably 90% chance that I've covered everything they're going to ask.